burnout from clinical depression or major depressive disorder, as an example, or any other affective spectrum state. All right, so I'm starting with this, all right, because we're talking about burnout. In one way, depending on how you think about burnout, people conceptualize it as a stress response or a stress phenomenon. I'm going to keep on touching on this because it's really important. One of the things that came out of the work at the Wellbeing and Burnout Committee since last APA meeting is that there's a dangerous conflation, a dangerous misunderstanding of like what burnout is and what it isn't. And the issue with that is that it can cause a delay in treatment. People can use burnout in a way in which it was never really intended to. This can cause people to either not appropriately address symptoms, or conversely, people can actually refer to, they can actually, when someone is just burnt out per se, they can actually say, well, they're depressed and not implement any organizational factors. So this concept in terms of what burnout is and what it isn't is very important. But again, this idea that burnout originally is talking about this idea of too long, too much stress for too long, resulting in emotional exhaustion. That kind of theme is where burnout started, but it's morphed a bit, and we're going to get a bit into that. Now, this is one of these slides that I have always utilized. And this is one that I utilized at the start of the pandemic. I'm not going to spend a lot of time on this other than to illustrate burnout is part of the chronic stress reaction, or people, the way they think about it. Now, they put depression as well as substance abuse, suicide, and post-traumatic stress disorder in this slide deck. Obviously, we can recognize those as health conditions, mental health conditions. But burnout also they view in that chronic stress reaction. So you may now be asking yourself, because you may have heard this talk in regards to burnout being a syndrome, all right, burnout being a condition. I'm going to start to like really maybe put some other things in our thought process in regards to maybe thinking about burnout as an occupational phenomenon, all right, as opposed to a diagnosable syndrome in the sense of a DSM-5 syndrome. I'm just going to start to talk about burnout and that occupational phenomenon as a sign or global sign of occupational distress, and important to recognize. But once we recognize it, we have to delve further and ask some specific nuanced questions to try to get at what is behind that global occupational phenomenon or distress. Okay. Okay, so the origins of the burnout concept. All right, so I'm gonna do this efficiently. All right, I believe, this was a disco ride at a baseball game or something like that. They were breaking like disco records or something of that nature. This was like a hurricane storm or something of that nature. I didn't even know that existed, like a desert storm. I forgot what part of the country it was in. They were out of gas. Yeah, all right. Gas crisis. Nixon resigns. Burnout. 1974. What a year. Isn't that like concerning like the similarities that we actually have right now between all of those type of things? But nonetheless, um, that was when burnout, the term, just came about, and it was conceptualized by Herbert Frunberger. And again, the idea behind it was high ideals and the need to repeatedly sacrifice oneself. All right. Now, the interesting thing about it is when you actually dig a bit deeper into when this concept was actually first introduced, it was actually stated that it would be very difficult at times to differentiate burnout from depression because the folks could look depressed. All right. So we're going to go someplace with that later on in the lecture in regards to the difficulty in differentiating burnout from depression and how, depending on who you talk to, they could actually be the same phenomenon. All right. Then we get to 1981. And this is when Maslow came up with what is now considered widely the most utilized, if you will, definition of burnout. Maslow and others consider burnout a syndrome, all right, a diagnosable mental health syndrome. There is significant debate back and forth in regards to that. That's why I underlined syndrome. The only place burnout is in the ICD-11, but and they refer to it as a syndrome, but they do not refer to it as a mental health condition. They refer to it as a phenomenon. This becomes rather important. Okay, these are the classic dimensions of burnout: feelings of exhaustion, professional inefficacy, depersonalization. Most authors agree when you think about the concept of burnout, the key component that they feel is most or they would say most tries to capture it are the sustained feelings of exhaustion. All right. This is what they feel mostly captures it. All right. Now, and we're going to talk a little bit about how each of these dimensions does or does not separate from a clinical depression, or do they even co-aggregate like we would expect in a syndrome? Remember, a syndrome is symptoms co-occurring together more than not. Okay. So this is the ICD-11 definition of burnout. I highlight the point that it refers specifically to phenomena in occupational context. It should not be applied to describe experience in other areas of life. So they're really carving this out as an occupational phenomenon. All right. Now, those of you who've either worked with people who have talked about or expressed burnout, and evidence will back this up later, that it is not just related to your work, and particularly with physicians where we're working anywhere from 10, 12, 14, 16-hour days, the difference between your home life and your work life can blur quite a bit. So again, even though they're putting it in the occupational context, some would argue that burnout can certainly exist beyond that. And anybody who's had to, particularly during the pandemic, when people have to have increased caregiver roles, whether it's with elder care, whether it's with their children, all the different demands, I think that they would attest to that. All right. So the point of this in terms of burnout is if you actually start to look at the original descriptions, like these are the three primary dimensions: emotional exhaustion, cynicism, and efficacy. But if you look at the original descriptions of what it was, this starts to look a whole lot like depression, or I usually like to use the term like broad occupational distress. And I kind of like to think that way because it encourages me to delve a bit deeper into what else could be going on or what I could be missing. All right. Okay. This is just a brief nod to there are multiple burnout inventories in addition to the Maslow burnout inventories, each with its own, if you will, dimension that is more specifically measured or focused on. What you need to appreciate, and there's going to be another slide that talks about this, there actually is no agreed upon definition of burnout. You may think there is, but there in the literature, there actually is not. The next thing you have to be mindful of is that there aren't validated cutoff scores in regards to burnout when you do these measures. So really what that gets into is that burnout is guided like an assessment or saying that someone is burnt out is really guided by the clinician's judgment, not necessarily by any validated cutoffs, nor by any agreed upon measure. So again, we have to really be careful when we use this burnout concept. Do I think it has utility? I absolutely think it has utility. But like all things, if it becomes overutilized, it becomes so watered down that it loses what utility it had in terms of its function. Now, these are the driver dimensions of classically burnout, but I also like to say engagement. All right. And this is taken from Shanafeld and Mayo Clinic Strategies to Reduce Burnout. I personally think it is for anybody who's thinking about system level interventions for well-being and burnout. I personally think it's the book to read. As a matter of fact, I would argue it is almost the only book you need to read. The key point to this slide, though, in addition to the 6 dimensions that all of you are aware of, is that meaning and work component. All right. All of this in terms of fostering meaning in work. I cannot emphasize that enough based off of the physicians and residents and those that I've treated over the years. Because even if you address all of these drivers, if you don't do it in a way in which it links to where the person has meaning in work, your intervention in terms of encouraging engagement and reducing burnout is going to be of limited utility. All right. Other terms that frequently gets associated with burnout that are targets of clinical inquiry: moral injury, vicarious trauma, compassion fatigue, second victim syndrome. All of these, in my mind, fall under that broad occupational phenomenon, global distress phenomenon. And you have to go in to kind of carve out a bit what actually is going on. Okay. For the purposes of this lecture, I will not go into great detail in regards to these various concepts, but they are absolutely there. They are absolutely real. In any, if you will, conversation of burnout, or global occupational distress, if you will, needs to have this in your, for lack of better words, your differential also, these concepts. Now, challenges with the burnout concept. As I mentioned before, there are no clinically validated cutoffs, all right, in terms of cases versus non-cases, okay? It relies on a clinician diagnosis. There's currently no accepted burnout definition or diagnostic criteria among practitioners. All right, so it relies on a practitioner discretion. Frequently, in my work within the Resiliency and Wellbeing Center, I will have either colleagues, I will have whether they are residents, whether they are attendings, whether they are fellows, also including whether they are law students. This is not an uncommon, if you will, referral. X is burnt out. They are stressed. They are this. You may think that everyone would maybe voice those three, if you will, dimensions. However, many people describe different things. It almost just comes to the point there might be global at times work overload, but once you get past that, everyone's burnout is everybody's burnout, so to speak. I mean, that's where you have to go deeper into the if you will, the global distress. Could that global distress concept and specifying it, as all people being experienced clinicians, could you say the same thing in regards to major depressive disorder or bipolar disorder once you get past this strict symptom history? Yes, you could. However, depending on the clinician that you talk to, but I'm the person talking right now, you may find more variability in any one particular report of burnout meeting those broad symptom clusters, or better yet, those broad system clusters of exhaustion, cynicism, and inefficacy can have so many things underneath it that you could be dealing with multiple manifestations of different components. So this is a long-winded way of me saying that it is very difficult to really have a true definition of what burnout is because of the ambiguities inherent in the concept. All right, next, in terms of the overlap with mental health conditions, and I'm going to have another slide on this. Burnout absolutely shares many symptoms with other mental health conditions, such as depression, anxiety, making it difficult to differentiate, as well as diagnose burnout as a distinct condition. This is one of the reasons why in the DSM-5 or in other manuals, it is not listed as a syndrome or a condition because it does not meet those criteria. Okay, now, this study by Verkelen and Bianchi was, and this is one of the 3 studies that I'm going to talk to you about today. They looked at this idea of burnout and depression overlap. All right. They studied, because there's been a lot of work done, probably at this point in time, probably over 1,500 studies, not just strictly on burnout and depression, but on burnout in general. And they wanted to examine this overlap between burnout and depression. Okay. So in the study, they looked at a total of 1,258 participants with an average age of 42. They assessed them using PHQ-9 as well as standard Maslow burnout inventory. All right. This was an appropriately powered study, and it was indicative of other studies similar to this in that burnout, there was a significant overlap of burnout with depression. Let me tell you more specifically what we mean by this. If you took the core features of burnout, emotional exhaustion, cynicism, inefficacy, you would expect for them to cluster together. They actually did not. Actually, the emotional exhaustion clustered more closely with symptoms of depression, as well as the other symptoms. Even when you control for emotional exhaustion and you remove it, the other symptoms still cluster more closely with depression than they did with then together as a burnout concept. In other words, they didn't come together as a syndrome. They actually came closer to depression, which is why researchers have been arguing that, depending on the researcher that you talk to, that one, burnout is either just a component of depression, like in terms of the continuum, or we have not had the effective definition yet to efficiently differentiate the burnout phenomenon, if it is a syndrome, from other affective disorders. And by that, I'm referring to major depressive disorder or clinical depression. So again, emotional exhaustion did not differentiate it did not link with the other symptoms to form a syndrome. It linked more closely with symptoms of depression. Now, the next thing they did a 5-sample confirmatory factor analytic study of burnout, depression, and overlap. All right. So this study, all right, what they were basically looking at, remember what I was talking to you about, the emotional exhaustion. All right. Authors argued to the contrary, that if you took out the emotional exhaustion piece, which they admitted could absolutely have a distinctive overlap with clinical depression, the other elements of burnout syndrome would, one, co-occur more closely together, and they would not link up with the depression. This was not the case. They controlled for the fatigue, knowing that this was a case. And still, the other two big factors still linked with depression. All right. So these arguments have gone back and forth, and depending on what side you fall on, you're going to have different views of it. I personally, just off of my own clinical experience, I think that I would agree with the idea that it is very difficult or challenging to define really what true burnout is. There's a very reasonable case to be made that burnout, the overlap between burnout and depression, could be one, burnout consisting in a continuum in a depressive continuum, depending on if you're a continuum person, or burnout could be in the more broadly considered heterogeneous category of depressive or affective disorders. Because remember, many people consider also depression actually is having a heterogeneity or other multiple subtypes or conditions in it. Hence, more interest in melancholic versus non-melancholic depression. If you look at some of the more recent studies that have come up, to people that have been practicing for a while, this is actually not news. We used to do this we used to do it more all the time, but there's been an increased interest in these subtypes of depression. So all of this is to say, the evidence clearly points to this. And this is kind of a take-home point. If someone talks to you about burnout or global distress, if you are not immediately also thinking of ruling out depression or something else, you've missed. You've missed. So the first step in differentiating burnout is actually really, the moment you hear it, is to think depression. The moment you hear it, I'm like, okay, let me think depression. As a matter of fact, I would outright almost say, for me, depending on who I'm working with, burnout is a diagnosis of exclusion. I work my way down to burnout after I've ruled out everything else, if that makes sense to everybody. Next, burnout, depression, points of convergence and divergence. So this study, all right, by Tavali, they were trying to say, okay, we get it. We get it. All these other scales, which there are many, have yet to actually prove that they can differentiate burnout from a clinical depression. So they set about doing it. And what they did, they proposed a new model, all right? They compared to other models, all right? They started with the idea, all right, we're going to take patients who are identifying or saying that personally self-identifying as burnout. We're going to collect a lot of data, a lot of factors, okay, in terms of their description of it. Then we're going to factor analyze all of this stuff, all right? We're going to reduce it down to its core elements, and then we're going to come up with a new survey that should better capture burnout because the original conceptualization of burnout was not done in this method. All right. So they said they're going to do that. They did this. They came about a general factor, and this general factor had components of emotional exhaustion, cognitive dysfunction, social withdrawal, irritability, excessive worrying, empathy loss, and some depressive symptoms. And then they had five specific factors. All right. So there's their survey. They had like about 30ish or so factors that were general, and then five specific: cognitive dysfunction, empathy loss, exhaustion, reduced work performance, and social withdrawal and insularity. Now, what they found in regards to this, they did find that there were some nuanced symptoms, but the Sydney burnout inventory is called. They still were not able to get to the point to where they could actually define a burnout syndrome. All right. So they argued again that this is not currently burnout is not distinct from depression, and that burnout and depression could share a set of non-specific symptoms and overlap. But what their evidence did point to, all right, preliminarily, is that perhaps self-diagnosed burnout may overlap more distinctly with non-melancholic versus melancholic depression, which makes clinically intuitive sense to me, because when I work with those, that frequently when the diagnosis starts out as burnout, and then maybe we diagnose or either it stays like not the diagnosis is burnout, it stays maybe, let's say, for lack of a better word, in the burnout adjustment disorder tree and not in the clinical depression. One thing that I tend to focus on is anhedonia and length. All right. If it's strictly organizational and burnout, I shouldn't see the anhedonia. I shouldn't see the sleep disturbance, the morning awakenings. Like that should be a very clear tip off. This may seem obvious, but you'd be shocked how long it takes for people to go into treatment, even when there are very clear signs of a severe depression. And that's because we use the term burnout and there's more focus on the organizational factors, when yet we have very clear symptoms indicative of a serious mental health syndrome. So I bring this up because this gives us some clues or some ways in which we can start to think about differentiating burnout, or the idea of just a pure occupational phenomenon of burnout, from a clinical depression. All right, so again, the non-melancholic depression versus melancholic depression. This might be our first key thing when we're starting to think about burnout. And again, remember, I'm saying burnout phenomenon, diagnosis of exclusion. I come to that at the end, particularly when working with physicians. I come to that at the end. I don't start with that. I end with that after I've excluded everything else. And some tips are, all right, is this a melancholic depression? Is this non-melancholic depression? Burnout tends to associate more, if we go by some of the more recent evidence, a non-melancholic depression and self-worth. It doesn't mean that if I have more non-melancholic features, the person's going to meet that diagnosis, but I feel like I'm starting to head down that path, which is more of a non-melancholic burnout path than a melancholic depression path, or severe, if you will, episode. Now, this was just the scales, the subscales of that earlier study that we talked about. Okay, so you can see burnout all versus depressed all. There really wasn't differentiation. Okay, and even in the cognitive dysfunction, the exhaustion, not a lot, as well as reduced work performance. All right, and those of you who've treated somebody who has said that they are not burnt out in their clinic, they're very clearly in the midst of a depressive episode. This also does not surprise me. The social withdrawal and the empathy loss. All right, so in this particular one, all right, the burnout group, if you will, burnout all right, they had less, if you will, social withdrawal than the depressed group. All right. And they had more empathy loss, and the depressed group had less, if you will, empathy loss. I'm going to focus on the social withdrawal. All right, in regards to that. All right. That part actually makes a bit more sense to me in regards to in focusing on that. And typically when I see somebody go into, they stop socializing, they stop their relationships, you get that level of disruption, particularly in their close circles. That to me always, even before this study, that was a marker that we're going into something else. That was the marker that we're going into something else, particularly depending on what population you're working with. But once there's an increased social withdrawal, not only are we potentially going into maybe what may be considered more of a depressive episode, we're disrupting our relational coping. All right. So this again, it starts to form a little bit of a picture in terms of different ways we can start to think about that continuum. Now, techniques for assessing and evaluating the patient. And notice, I already tipped it off. The system. The take-home point of this is that if you seriously want to work with folks and differentiate the burnout phenomena from, let's say, clinical depression, not only do you have to evaluate the patient, you also have to evaluate the system. And I didn't strictly just say their social history or their family history or things of that nature. I said the system. By that, I mean their work environment. I think if you put those two things together, you're in a better position to say that we are either in a burnout / adjustment disorder / acute, if you will, stress reaction versus a melancholic depression versus a severe period of generalized anxiety versus some other form of significant mental health crisis. So now let's go over a couple of these things. All right, now, the first thing that you need to do, in my humble opinion, now I'm drawing on clinical experience. I'm not pulling from studies. I'm pulling from the actual work that I've done throughout COVID, along with others, all right, in the Resiliency and Wellbeing Center. Frequently, and it's not uncommon that probably, let's say, particularly with residents, 30 to 50% of the complaints will be, I'm burnt out. I'm burnt out. And yes, you are. So let me start by that, because I said in terms of how I think about burnout, it has changed. Yes, I view it as a form of, if you will, global occupational distress, and is a beautiful entry point to a conversation about your health. I take that from, I used to do a lot of work in cancer survivorship and this idea of distress. The 6 vital sign. When they come with global distress, we don't necessarily know what it is, but the important thing is that you're coming and that we acknowledge the distress. If you do not acknowledge the person's distress and the role the environment has or could have, I think you lose people in the interview, and rightfully so. Rightfully so. If someone's perception is that they're dealing with stress and it is largely due to the work environment, we need to validate first. Validate where they are at. All right. I find that if you validate and you listen, but you have to listen for the specific stressors. And it helps if you have some knowledge of what those stressors are in a work environment, because now you're speaking the language. All right. This helps reduce the shame and normalize. Then we can start to maybe get into a little bit of education about what burnout is and what it is not. Then you can start to discuss depression. And then that's when you get into, and I'm usually upfront with people. I'm like, listen, we have such high rates of suicide in physicians. I go from the other end. We rule everything else out first, and then we get to burnout as a diagnosis of exclusion, or it could be comorbid, but we have to go the other direction as opposed to waiting to uncover the diagnosis after we start with burnout. So again, this just talks about, if you listen, you do these things, you go from high distress, hopefully to eustress or neutral. Again, this isn't anything that any clinician should not know how to do. But if I had to pick something that really helps with this, it is a sincere listening, and you actually know the stressors of the environment. Probably my advantage in terms of working in the Resiliency and Wellbeing Center is that I've been in GW for like 18 years. So I know the hot points. I know the stressors. I know like which elevators work and which don't. I know, if you will, some of the mannerisms of different types of people. So that is very helpful. Next, evaluate the systems. All right. Again, I brought this slide back for a reason. Every single one of these elements can be evaluated on your interview. The workload, the control and flexibility, work-life integration, social support and community, organizational culture and values, and efficiency and resources. And by evaluate, I mean do it just like you would do a review of symptoms. Just like you'd assess for affective, psychosis, cognitive, behavioral, anxiety spectrum, trauma. You list these in you evaluate each one. All right. I have a little bit more experience, so I know specifically some of the things that I'm looking for. But just you even asking the question in a curious way with the patient, you're going to start to get a picture of what is driving or not driving. And you want to be curious about it. Ask for examples, ask for what they mean. And not invariably, someone will say, well, you know what, actually, it's actually not quite that bad because when I did this or X, Y, Z, or they will quite clearly lay all of this out. I think if you do the system level review, all right, in terms of these specific drivers, this is going to, again, help you along that continuum, burnout adjustment phenomena versus severe melancholic depression, even more increased suicide risk. Now, let me give you an example of a way in which I look at things. All right. When you talk about burnout, and we know that burnout is organizational primarily, one of the biggest effectors on burnout, or the burnout phenomenon as people talk about it, is leader behavior. These are the 5 elements of leader behavior that promote engagement: include, inform, inquire, develop, recognize. Recognize. All right. This is what, and this is taken from Mayo Clinic Strategies to Reduce Burnout. These are the 5 things that they assess for in their leaders. These are the 5 things that they measure. All right. And they've produced work on this, studies. Oops, not that. That was the one I wanted. Okay, this one. I'll go back to the other one. Sorry, that slide was out of order. They found on this 60-point scale that for every 1 point increase in leadership score, okay, there's a statistically significant 3.3 reduction in likelihood of burnout and a 9% increase in likelihood of satisfaction. Okay, the aggregate leader behavior index score on the unit explained approximately 11% of the variation in burnout and 50% of the variation in satisfaction. The single biggest driver of professional satisfaction was the behavior of each individual's immediate supervisor, to the point your immediate supervisor or middle manager, and I know that there are people in private practice or XY, but I'm doing this in terms of organization. If they can do these behaviors that I just talked about, and they can actually make sure that they find what you love, all right, you can have up to a 50% reduction in burnout. If your leaders do those behaviors and they find out what you love about your work and they make sure you do it 20% of time, 20% of the time. And you can ask anybody who I directly supervise, I always ask them the same thing. What do you love? And I'm going to promise you that you do that the equivalent of 1 day a week. And I can't promise you anything else other than that. Frequently, I can get more than that, but that's where I start. Now, those behaviors, these are the behaviors that we want. But what happens when you don't get that? All right. What happens when people start to get excluded? They get iced out. Then they get left off the communication chain. Then they get dismissed. Then instead of getting developed, they limit and obstruct. And then they get critical and punished. The key word here is publicly. Let me give you an example. Resident, let's say peds for right now. Resident it's been having difficulty at home navigating the transition into intern year. All right. They're just not able to really get in, get gel. They're missing their family, and they also just maybe recently had a breakup. They were late to a couple of call shifts, so now they get excluded or iced out of the social circles. Okay. So that on top of it, then they get out of, if you will, that social network, that kind of informal dialogue that's more important than rounds or whatever. And so then they get also left off of communication chains or opportunities. Okay. When they bring up concerns about how they're doing or what they're seeing or whatever, those concerns are not taken seriously. They are dismissed. All right. When opportunities come up, the person is labeled as the X, Y, or Z problem or blah, blah, blah resident or something of that nature. Their professional development is limited and obstructed. Then the thing that puts it over the top, someone either directly or whatnot criticizes their performance instead of pulling them aside and talking to them individually. You have now just increased burnout, and you decrease their self-worth. I made that story up because it's an amalgamation of what I frequently see in regards to particularly what leadership behavior can do. And this behavior can be corrected in regards to proper training, proper documentation, proper vigilance in regards to it. But I've seen it so much. I use a resident as an example. I could use anyone along their continuum of the medical journey, whether you are a medical student or whether you've been practicing for 20 to 25 years. All right. Everyone is vulnerable to this. And again, it happens over time. It doesn't happen usually within a week or 2 weeks, but it happens over time. All right. And again, physicians are known to be resilient. So they'll deal with this. They'll kind of carry water for a while. But then you reach a breaking point, and that's when you start to see more, even more of these symptomatic phenomena of either burnout phenomena or going down the road to potentially this type of issues, these stressors exacerbating an underlying depressive disorder. Okay, now, next, remember I told you, assess the system. All right, assess for responsibility overload. But here's my thing, new responsibility overload. Again, this is my clinical experience in regards to this. And this came from, it didn't come from Bianchi, but again, when I assess role overload, people typically adjust to changes in their roles. The first month or so can be rough when you make that transition point to anything, but they typically adjust. What I look for is new unanticipated responsibility overload. I think that definitely makes me start to think about when there's other things going on, particularly in the home environment. That makes me start to think about, all right, big factor, obviously, for depression as well as burnout. But when I start having all these things start to add up in the organizational system, I'm like, maybe I need to start leaning towards burnout phenomena or whatnot, after I've ruled out everything else. So, but again, this is a common thing I see. New professional role, new home dynamic, pretty much I'll tell you the two most common, easy ones. Very, very, very easy. New child, new parent with dementia. Easy. I can't tell you how many times I've seen that. All right. And then potential risk for role overload or sick family member. That's the other third variant of it. All right. But it's typically that cascade. One of them can get handled. All of them, not so much. All right. Particularly if one has an underlying mental health condition. Oops, that came. Next. Remember that graph I showed you before, which I just brought up now? I do actually look at the social withdrawal and the empathy loss. I do look at, all right, is the person actually making an attempt to stay socially engaged, or are they actually really, really starting to withdraw from their environment? To me, that is particularly in a younger cohort with a lot of relational coping, that is a massive, 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 massive red flag, almost to the point to where, because I'm a dean, I get concerned whenever I see people having an extended amount of social withdrawal. I view medicine as, a Peloton, like, a Tour de France. Like, it's very useful to stay with the group. All right. Not that you have to do everything that the group does, but without that, if you're trying to do it alone, that's when a lot of the problems start. So that to me is definitely a red flag, and I look for that. All right. And then these are just other potential red flags. Again, I've painted this as a continuum. People can agree, disagree with this. I'm just putting this out there. All right. And again, remember what I said. I start from most severe, and then I work my way back. Here's some other things which should be obvious, but it's important to put them out there. Previous history of depression, history of MDD or bipolar disorder, self-medication. All right. Immediate changes in work environment having no effect. Let me just pause there for a moment. That's actually a big one. People will sometimes talk about burnout, and if you don't dig cleanly enough, you will not actually realize that people actually did make adjustments to their work environment, like pretty solid ones, and they're not really having an effect. In my experience, if let's just say it's like the pure burnout phenomena, mostly associated with organizational stressors, I can actually get a response or an improvement working with that person as well as their immediate supervisor or whatnot, maybe in like 2 to 3 weeks, because we can change the work environment. We can make immediate adjustments. Remember, what did I just tell you? Anywhere from 20 to 50% of symptoms can be adjusted just by the leadership behavior, just by being recognized, just by being included. You'd be shocked at how fast that can happen. Then you can deal with the EMR. Then you can deal with everything else. If I don't see that, and we've done some things or some stuff has been done, and we're starting to get disruption in sleep, and then I'm like, whoa, either I was off and I did not catch the more severe clinical depression, or something isn't quite making sense. So I just want to focus on that a little bit. Okay. All right. Next, this is just adapted from, these are just common facts in regards to physician suicide. I think it's important to know the facts. People have seen the facts. I don't necessarily want to continue to bore you, so to speak, with them, but we can't talk about them enough because we're dying at an increased rate due to physician suicide. Okay, untreated or inadequately managed mental health conditions. Physicians are less likely to be receiving mental health treatment. All right. Okay, we know the suicide rate among male physicians is 1.4 times higher than the general male population. And among female physicians, the relative risk is even more pronounced, 2.27. Suicide is the second leading cause of death in 24 to 34 age range. Okay. 28% of residents experience a major depressive episode during training versus 7 to 8% of similarly aged individuals in the US general population. So consequently, I could just take this data point alone to back up what I say, and that's kind of part of my approach. I'm going to rule out the depression first, and then I'm going to get to the burnout. All right. Now, obviously, you go in and you see things, and as you're doing things, you're moving things up and down your differential, if you will, as you're getting your data, as you're doing your system level assessment. But again, think about that number. Okay. Okay, among physicians, risk for suicide increases when mental health conditions go unaddressed. We talked about that. I'm going to put a particular note. I'm going to talk about, I should have highlighted anxiety, but insomnia, that's a big bugaboo of mine. All right. I'm not just talking about, if you will, lack of sleep, but inability to sleep. All right. That a lot of times that's like the final, if you will, defense. When people can't sleep, they cannot function. All right. Okay. 23% of interns had suicidal thoughts. And to be perfectly frank with you, I actually think that that's an understatement. I think that that's low. All right. So I think that that is low, but you have to know that these things are quite common. We already talked about the drivers, and this is a very interesting one. When they talk about the facts, unaddressed mental health conditions in the long run are more likely to have a negative impact. Notice I highlighted health. I think we actually need to move away from mental health, and I would say unaddressed health conditions, period. Period. Our self-care sucks as physicians. Sorry, y'all. I've been looking at it. I mean, and broadly, we know that this false divide between mental health and physical health and X, Y, or Z, all it does is increase stigma and shame. All right, I'm a CL psychiatrist. So I know good and well that your untreated other health conditions are absolutely going to contribute to your allostatic load. They're going to contribute to you developing mental health conditions. So we need to move away from that, because people, even if they're not having an overt burnout phenomenon or clinical depression, it's the same as like having a silent hypertension. All right, if you're not addressing your health conditions. So that's why I put it like that. Don't get, like, somebody may not come to you with a mental health condition, but their other untreated health conditions are just as relevant. So I encourage that. And also that becomes a very useful gateway and point of discussion. In the Resiliency and Wellbeing Center, we have a physician assistant as well as a therapist, as well as myself. And we have a lifestyle component in terms of where we also address all aspects of whole health. All right. So briefly, just a few evidence-based interventions to reduce symptoms of burnout. All right. Again, mental health education obviously can help. Organizational support. And here's something else I want to touch base on: peer support. Peer support is absolutely incredibly massive. Even if the organization in itself is dysfunctioning, even if there's issues with the leadership, people will link together. They will support each other if you have peer support set up. At GW, Brandon Court actually introduced the Caring for the Caregivers program, and we've had some good success with that. As a matter of fact, if you talk to Peter Yellowlease, a pretty well-known chief wellness officer who wrote the physician suicide cases and case commentaries, which I consider a must read, he talked about the power in regard of peer support. So I wanted to bring that up. All right. And then Obviously, there's other individual focused interventions like stress management, mindfulness-based interventions, CBT therapy. Again, these can help address the burnout phenomenon. No, there's not a burnout syndrome, but I feel the money in this stuff is doing it before you actually get symptomatic. That's always my goal. Let's start to have that conversation when you actually enter the organization. I'm very pleased that at GW, we recently implemented resident opt-out appointments. Every resident, every resident now, you're automatically set up with an appointment with the Resiliency and Wellbeing Center that you have to opt out of. We are having great success with that. I'm not going to give you the data, but it's similar to others, such as University of South Dakota, where they have had opt-out appointments, and they've had anywhere from 70 to 75% of folks keeping those appointments and 20% of them following up. Brown University, I believe, my colleague, Kelly Holder, I want to say they did it with their students, same data. Once you introduce residents or folks, once we introduce clinicians to these concepts early, we can intervene earlier. And then these are just common things that you all have heard about: the reducing the workload, increasing autonomy, improving leadership. I talked about that, but again, if you don't link it all around where the person finds meaning in work, it's going to be like kind of jigsaw puzzles that don't fit. All right. And then this is a complicated slide. I'm not going to go into every single aspect of it. Why am I bringing this up? This is taken from Mayo. This is to tell everybody that every single one of those organizational issues has an evidence-based strategy. Every single one, at the individual, work unit, or organizational level. And yes, notice at the individual, because we have superlative private practice practitioners. And here I'll say one of the biggest things that I've had to work with when I've worked with folks that are more solo or smaller is the ability to say no. As an example, this may sound simple, but it is not. How you really leverage it is knowing your personal as well as in your professional life. All right. And then this is the other one in regards to the other drivers. All I'm saying is that there are many, 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 many evidence-based interventions. And if people want to hear more about them or talk about them, either you can go to the Mayo Clinic Blueprint Strategies. I'm happy to sit down and talk with folks in regards to this, but they're at every level: individual, work unit factors, organizational factors. In addition to that, if you wish, the APA Wellbeing and Burnout website, which we are revising, has a plethora of resources. And if you really, really want to delve into a resource that was specifically designed for physician suicide and well-being, go to the APA Workplace for Mental Health. That's from the APA Foundation, which is different than the APA, and go to their toolkit. All right. Their well-being toolkit. It is evidence-based. It addresses many things, including stigma, shame, suicide, use of employee assistance programming, as well as it addresses some credentialing issues. It's a very superb toolkit that nobody knows about. Nobody knows about. And one of our missions in the Wellbeing and Burnout Task Committee is to actually get the word out about that. So I'll leave you with this. All right. This is kind of the mantra of the Resiliency and Wellbeing Center. Is based off of self-care and whole person care. Each one of these elements surrounds purpose, and there's 6 of these elements. So when you are able to, and I don't have this slide in, what I learned from COVID is you need a very short definition of well-being. And this is mine. Okay. Meaning in your work and purpose in your personal life gives you every opportunity to have well-being, purpose, and meaning. Okay. So regardless of whether it's a burnout phenomenon or whether it is a depressive disorder or anything else, our ability to find purpose in our personal life and meaning at work gives us every shot at growth and well-being. My definition, not yours. But the key thing is anything that you say or that you come up with is going to be stronger than what I just told you. And if you do it in collaboration with people that you care about or your patients, it's going to be even stronger. So you come up with yours, but it's got to be simple. It's got to be quick. You got to be able to pull it out. no matter where you're at. So with that being said, thank you for your time, your patience. Hopefully, if I shared something with you that you didn't know, I did my job. If I didn't, well, then I was being a little bit too academic, and I asked for your patience. And if I did it right, then a lot of respect to a lot of patients who taught me the right stuff. And always remember, growth is always a realistic option. All right. Let's see if I see about the questions. What do we got here? I'm gonna stop the share. If we got any questions.
Okay. Yes, Dr. Adrian Brown has a question and a comment. Dr. Brown, did you want to unmute and ask these questions?
Sure. So I think the comment is actually sort of answers my question, which is it seems to me that burnout is just a more acceptable way of talking about depression, that it's okay to be burnt out, but it's not okay to be depressed. And so it doesn't really matter to me what, what you call it, as long as people are, if it's a portal for people to get into treatment, fine, tomato, tomato, I don't care. Let's get you the help you need.
Yes, I absolutely agree with you based off of the evidence. However, what you might want to go to is that it's important to differentiate or to understand the different contributing factors. Might be another way I would put it. In my work, yes, we want to give appropriate accountability to the organizational or the organizational factors that can be done to either improve whatever you call it, a burnout phenomena or an occupational induced depression. And then we also want to have appropriate accountability for the patient in regards to them doing the appropriate treatment strategies and things of that nature. That is why it is important, because when you differentiate burnout between depression, it's another way of differentiating the stressors and what you can target. That's really the main point of it. So that was a great question. So if that wasn't made clear, hopefully that's clearer. Please, other questions. Let's see. I think there's a fine balance between developing and nurturing, and with at times having to address poor work performance issues, which could be due to burnout. Any advice on how to manage this? Do you think our residents and fellows have a better handle on work-life balance? All right. Important question. All right. Yes, I do have thoughts in regards to handle this. All right. The idea in terms of poor performance gets into how you actually approach the remediation plan. All right. And how you delve into it. There's usually not enough attention given to, frequently people will address the performance, but they won't address, I'm going to borrow a concept from Grip, they won't address the demoralization. All right. I actually have been in that situation before. What has worked, depending on what the level of the poor performance is, we also have the performance improvement plan while they are seeing a therapist or someone from the Resiliency and Wellbeing Center, and they give us permission to coordinate strategically with their program director. So we're addressing the demoralization component as well as improvement in skills. And once they get some then we're in a better position. That's an important topic. And then we'll see here. Any advice on do you think our residents and fellows have a better handle on work-life balance? I think they have a better awareness of it. I do not think that they have a better handle on it. I think that they have less stigma and shame in terms of talking about these things than, say, I'm old, you can see the gray, than we do. But I do not think that they have a better handle on it. And I can give you specific reasons why. I can tell you specifically because I've been in situations where people will talk and they will still work themselves to exhaustion because they don't want to let their colleagues down, even though you can come to sessions that are completely free at any point in time, everybody's working on that. Okay. Is there any way to get a copy of the slides? Sure, yeah, absolutely. No problem. Are there neuroscientific psychological findings that substantiate the concept of burnout and emotional fatigue? Yes, I did not share those slides because I was trying to, or those concepts, because I was trying to hammer home a certain point. With no apologies, in that I'd rather that you start to think about burnout as a way to start a gateway to discussion and not miss depression, as opposed to thinking about burnout as its own separate syndrome. So that is a bit of a bias of mine. Now, with that being said, there is authorship out there that points to burnout as its own syndrome. There is authorship out there that, and I'm blanking on the study or whatnot, that is starting to claim that in terms of, if you will, more on almost a kind of genetic basis, like those that are more susceptible to burnout. I think that stuff is, in my humble opinion, still evolving. I do believe that there probably is a burnout phenomena. We just have yet to fully understand and describe it in terms of where you could actually call it a syndrome. So, all right. Okay, let's see here. So we're gonna, okay, thanks, Connie. Question: with change in residence hours after Libby's on, how much you understand the increase in suicidal ideation in trainees? All right, let me pause. All right. I can actually expand this question. We've done a number of things in regards to training hours, benefits. I can go to medical school, pass, fail, all of these things. I think the inherent challenge is this is a bigger concept, and I've talked with many people about this. Is this goes back to meaning in work and why are we in medicine and what do we reinforce? Even if you have X, Y, or Z duty hours or this, that, or the other, which we do, and I think this is very much warranted. If you do not feel in control of those hours, if you do not find meaning in them, if you're not doing meaningful work, that is a problem. If you do not feel recognized, that is a problem. If you feel I can have you work for 3 to 4, I can have you work for 3 to 4 hours a day. If you do crap work and you feel as though you're doing harm, that's not going to help you. The time isn't the issue per se. It's the actual what you are doing during the work. This is why, despite all of our interventions in, let's say, even medical school or whatnot, people are seeing this right now. We made step 1 pass fail. Guess what happened? Step 2 became an all winners take all, if you will, exam now. Does anybody know what the average step 2 score is right now? You want to guess? Y'all who remember?
Now,
Yeah.
today, I think it's like 72 or something, and I might be off.
Okay, yeah, you bet that's back in the day. All right. The average step 2 score for all you who remember, I barely remember, is 250. To let you know, that would have been like the 85th or whatever percentile back when I was taking it. In other words, it's not about these other interventions, it's how we start to craft things and how we form meaning. And then the other thing, I'll be honest with you, is that physicians they have so much invested in their careers. And this is, again, I would encourage people to read Yellow Lisa's book, Physician Suicide and Case and Commentaries. They have so much invested in their careers, they cannot picture themselves doing anything else. They cannot. That's a separate, their identity can be so invested in it. Where does this become relevant? If they are not meeting their expectations or goals for their careers, they will push and push and push and push and push. All right. Sometimes to the point of death, in my humble opinion. All right. This is not me putting it on the physician. I want to be very clear here. I want to be very clear. This is not me calling out any physician or clinician that suffers from depression or burnout. We as an organization must do better in working in stigma and shame and educating and saying, no, you do not have to do it this way. You do not have to define meaning for yourself or whatnot by working yourself into exhaustion. There's other ways. So I put that squarely on the organization, whether it's depression or whether it's burnout. I could care less. Like whether I think the organization has an absolute duty to account for accessible pathways that are reliable for physicians as well as education. Now, once you get to that, it takes two. But again, please take what I said in that context. I am not in any way, shape, or form trying to blame clinicians or whatever in terms of their drive and their identity. My point is, I think we as a culture in medicine created this. We as a culture, and I am a part of that too. I am a part of that too. I went through the same system everybody else did. So we just got to have conversations about it. I personally think that I think that we obviously don't have, we're working on things, but the real solutions haven't come yet. And I personally, I'm going to be curious in terms of what some of these young clinicians, these young healers with different thinking come up with. But yeah, those are I could elaborate upon that, but it's an apt question. Please, any other questions?
I don't have a question. I wanted to make a comment, if I may.
Oh, go ahead.
Yeah, this was fantastic, sobering, but very informative and very informative. And I just want to say, I really like your focusing on the person and the system. And this, just a brief comment. I'm doing an independent medical examination that I'm actually writing up. And I looked at the examples you gave of poor leadership, and the person who is now suing a company, the person she reported to is guilty of every single one of them, all 5 of them. And what I was reflecting on is that I don't know if she mentioned burnout, but it absolutely applies. And I'm going to go back and take a look at my notes. You know, I've been thinking about depression, but I had not thought about that as part of her clinical constellation. So this has been really helpful. Thank you.
Well, happy to be of assistance, Connie. I mean, you know, again, we have to, I think it is, I think it's important for us to think about it. And I'm glad it was helpful. I'm so happy to watch the Psychiatric Society ask me to give the lecture. And for those of you, I tried to be a little bit different because believe it or not, from the past 4 years of being a chief wellness officer, I swore never to give another burnout lecture again. Because people, no, I swore, yes, I swore never to give. I'm serious. I swore, I was like, I'm never giving another burnout lecture. They're like, huh? I'm like, nope. I recorded them on video. You want to look at them? No, because people would like they throw stuff at you. I mean, they're like and they're like, we don't want to hear about burnout. We want to hear about solutions. I'm like, that's cool. But when Matt and folks ask me, I'm like, all right. Let me see if I can put a different slant on this to do something important and turn the conversation to treatment for depression. All right. As an example, in Dr. Agarwal from the APA Foundation, when we were in the Wellbeing and Burnout Committee, as well as there was a Chief Wellness Officer Summit last meeting. And he said something very important. What do we as psychiatrists have to contribute to this conversation about well-being and burnout? Why are there not more psychiatrists or on the chief wellness officers or chief well-being team? Believe it or not, you think there'd be a ton of psychiatrists, but actually they aren't. There are not. There's like not a huge amount. I personally am pushing for the psychiatrists need to be part of the well-being conversation, which has a lot of different components to it. You can get into lifestyle integrative medicine, but I think we have to own depression. We need to own suicide. We need to be very clear with folks in terms of, just like Adrian said, like, no. Let's call depression, and let's get some treatment. All right. That I think psychiatry has a voice and a lane in every aspect of this country and organizations in terms of owning that, amongst other things, as well as I think that would decrease stigma. And I also think that people need to discuss and tell real stories. We talked about this in the meeting about, particularly clinicians, about burnout and depression. I'll raise my hand. I've been burnt out and I've been depressed. What I would say a burnt out phenomena. I have my own views. I thanked my training that I could tell the difference. In my humble opinion, for me, the key thing was anhedonia. All right. But I think we need to start to have these conversations because trainees feel like, even despite all of this, it's one thing to talk about it or to read about it. It's another thing when the person is training you that hopefully you trust to some extent. It's like, no, this occurs. And this is how I got through it. Let me talk to you and maybe we can help you figure out your own path. So I definitely believe in that. We have to have more conversations about it. Like this, personal conversations, not just, I think the grand rounds, the plenary sessions and stuff like that is great. But if you're not, this is why WPS in this community is so important. If you're not having these kind of conversations, more intimate, I think that, because this is where the culture changes. That's my opinion. All right, please. Rami, someone else had their hand up. Yeah.
So Lorenzo, you walked into a trap I was about to set for you. So you made this very easy. So Anne-Marie's laughing. She probably knows where I'm going with this. So in terms of a conversation, I would probably consider calling on you if you have time to do a critical conversation.
Oh, yeah, I did watch. I forgot about the critical conversations. Yeah, absolutely. Anything for WPS. Sure. I'm happy to do so.
Excellent. Because I mean, this was a terrific talk, as Connie said, but when you talk about having a conversation with peers and colleagues, I think it would be fantastic.
Yeah, happy to do so. Happy to do so. I mean, we have to have, we have to have conversations and we have to have different points of view. We have to have different points of view. We have to be willing to challenge. Now, I mean, I don't want to challenge somebody's personal story. That's your story. But we need to present different points of view. We need to question this evidence. We need to think about it. And then something, so I'm happy to do so. Just like, just get in contact with me, Matt, somebody reach out. We'll make it happen. Yeah.
We will be in touch, but thank you very much. And it's very challenging. I mean, I listened to everything you were saying and all the kind of pros and cons, but it's challenging not only for ourselves, but when you are in an organization, and particularly when you talk about leadership, it's hard sometimes making tough decisions. And as psychiatrists, inherently, we're trained to be nurturers, I think, more than any field of medicine. But it's sometimes really hard walking, as I said in my question, it's sometimes hard walking that very fine line.
Well, yeah. In that spirit, I mean, I'm going to let that. Does anybody else want to follow up on Rami's comment?
Well, my guess is too, Ramia, that, I assume you're speaking from personal experience in terms of running Loudon, but I'm sure you get pressured too. So, and you're supposed to solve something and yet be also thinking about your staff's well-being, and yet you're getting pressured from above, would be my guess.
Yeah, exactly. And then you want to develop and you want to support, but at times it's just very challenging. To your point, you do get a lot of pressure from above. We're trained to care about people, whether it's our patients or whether it's our colleagues. So it is a challenge, but I love what you said though, Lorenzo, that give everyone a day to do what they love. I think that buy-in from everyone is incredibly important as well. If people come to the table happy, you have a happy community and a happy workforce as well.
Absolutely.
So,
I mean, my own personal story with that, the first time I was like really, 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 really super duper burnt out. I was medical director of psychiatric and behavioral services in the hospital. It must have been about 2010 or 11 or something of that nature. Everything was going phenomenally well. Then, like everything, what goes up must come down. Tough period. Tough period. And I still remember, it probably was like maybe 2012. I'm not sure when it was, maybe, but I was, those of you know Lisa Catapano and Indra Kinkin, they could probably tell you the story. I remember coming into their office and I could tell they're looking at me because I sounded incoherent because I was trying to do too much. I was caring too much, trying to do too much. All right. And I still actually remember Indra came to me in the grand rounds or whatever. And I was just sitting there like by myself. Now, like I was back, and she's like, and she said it in a calm way, but she's like, Lorenzo, are you all right? Are you? And I'm kind of, I'm like, look, I'm like, got that machismo. I'm like, what are you talking about? You're asking me if I'm all right. Are you all right? Look, did you take notes on the grand rounds or something like that? But anyway, so I wasn't. And I remember I was like, that's it. I'm done. I think I was in Chicago at some kind of conference or whatever. And I remember I made that decision. And so I think I went to like either a Nordstrom's or something like that. And I was just buying clothes because I was just like, all right, because I was just having the retail therapy, Prada this, Gucci that, blah, 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 blah. I'm saying this is a true story. I'm sitting there like I was like, okay, I was burnt out, but I wasn't like sad or anhedonic. I'm just like, all right, that's it. All right, blah, 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 blah. Kathy Crone called me and said, Lorenzo, how are you doing? And she's like, Lorenzo, I need you to slow down. I need you to not do anything, and I need you to take a break. Kathy Crone was probably the only person who could talk to me and do that. Shortly after that, boom, 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 I take a break. Then I get asked to go to the dean's office. I'm not here talking to y'all if Kathy, I'm completely convinced of that, if Kathy did not make that phone call while I was in Nordstrom's, buying clothes. But hey, that's why you invest in relationships. True story. I've told it many times. I usually don't include the Lisa and Indra part. But to your point though, but ever since that, I kind of watch my nurturing spirit. I got to keep a little bit of myself, regardless of what is going on or how many people or systems. That's just me. I'm just sharing. Take from it what you will. Like I said, I mean, if Kathy hadn't called me, I mean, y'all might have seen me like in Tyson's right now or something like that. Having fun, but still.
I think it's interesting about the, know when to say no.
Yeah.
I think that is so hard for so many people, and especially people who, want to achieve, and want to make sure that everyone is, satisfied with their work and what they're doing. So it is so hard to say no.
It's very hard. Now, I want to go back a little bit because I'd also talked about the depression. I think that for me, I have to be really cognizant of burnout. Because to me, that could easily flip me into a depression if I let that go too long. That's my own personal take without getting into the evidence base or whatnot. So, I hence, Kathy, to your point, you got to know when to say no. All right. And to me, I think like, for instance, critical conversations, that's not a no because I find meaning in the conversations and what we're doing here. This is how I reconnect to my people. All right. Someone asking me to like do like go on to NBC and talk about the recent our DC Attorney General suing TikTok. Not that much. You get older and why? I mean, I'm not knocking anybody who did go on Fox or NBC and do that or whatnot, but it's not my lane and I don't find meaning in it. So that to me is an example of like a no. Like, even though I want to help my colleagues, I'm like, that's kind of a no. Thanks. You get wiser, you learn what to pass up. Not so much.
This has been just terrific. So amazing. I mean, it's obvious there's so many people still here that this conversation needs to be had. I mean, it's very, very important.
Yeah.
And serious. I mean, it's really serious.
I agree. I mean, I'm kind of curious what Israel and Amina have to say. They've just been sitting here. I see their pictures, but they're not like, and I don't know who they are. I mean, like, they're just.
Hi, good evening.
Okay, there it is.
Sorry, I was like en route during the talks, but I'm glad I was able to listen in. I'm a child psychiatry fellow at Georgetown in my second year.
Oh, okay. Cool.
And so this is all resonating very deeply with me. I think going through the trenches of training has been difficult, and I learned some new things tonight. So I thank you for your story, for your expertise. I really do appreciate it.
Yeah, well, thanks for joining. Thanks for like hollering at us. I so appreciate that. That's so good.
Dr. Norris, if you don't mind, if you can send your slides,
yeah.
I can then forward that information to everyone who participated along with their information, how to claim their CME credit for tonight's talk.
Absolutely.
And that way we can put that together for everyone.
Absolutely. And I'll do that. And then now I'll make an ask too. If anybody has any ideas, big or small, for, I use the term globally, well-being and burnout, but it could be anything that you think is relevant to physicians. Send it to me. And because I want our committee, the larger AP Wellbeing and Burnout Committee, to talk about it. Like, for instance, a group of residents came up to us in Baltimore at the Mental Health Services Conference, and they wanted to talk about physical safety on the hospital floor. I'm like, well, that's not actually in my well-being burnout lane per se, but I'm like, that's a damn good topic. Why not? Let's talk about it. Why? Who am I? I'm not going to say I'm not going to say no to that. Let me at least maybe put you connected with the right people who can do it. So if you got anything that's on your mind or whatnot, let me know. If at the bare minimum, I can filter it up to Rashi Agarwal, the chair of CML, Council of Medical Education and Lifelong Learning, and they can put it on their to-do list. Again, APA, education, policy, advocacy, all that good stuff. I mean, you could probably also give it to Connie too. I mean, Connie, what's you're like rep? What you always have so many like.
No, Area 3 rep. Rashi is in Area 3. So
Okay.
she's a perfect person.
Connie,
Okay.
feel free to say no.
Oh, but did you see how I handled that?
Yeah. All right. Look, y'all.
Right.
Okay. Look,
Thank you.
it's been real. I do have to like go now though, because they've been my dogs are like trying to barge into our city office or whatever, and they're getting like kind of irritable. So look, everybody, it's been good. Heck, the conversation, I always say that the best parts of the meetings or the talks are always the conversations that happen afterwards. And this was an example of it. Thank you all so very much. All right.
Thank
Very
you.
good.
Thank
All right.
you, everyone. Have a
Take
good
care.
night.